start with improving medication use in geriatric patients. So I have three objectives. The first is to identify the August 2021 FDA approvals and CDC Advisory Committee on Immunization Practices recommendation for COVID-19 vaccination and how these apply in geriatric patient populations. The second is to identify how newly FDA approved pneumococcal vaccinations compare to the previously approved vaccinations. And then finally, to identify ways to improve geriatric patient care collaborations between pharmacists and prescribers. So we're really excited to talk about all of these. And I will start by saying that I am by no means the expert in some of these topics. They are quite evolving as we speak, but it is worthwhile to bring to attention some of the changes that have happened in the last month and to draw your attention to changes that are on the way even. So on August 13th, 2021, the ACIP made an interim recommendation for the use of an additional dose of the Pfizer BioNTech COVID-19 vaccine. I've quoted the exact recommendation that was made. So this is for persons greater than or equal to 12 years or Moderna COVID vaccine for persons aged greater than or equal to 18 years after an initial 2-dose primary mRNA COVID vaccine series for moderately to severely immunocompromised people. That's a mouthful, lots of things to say in there. So when we look at this, there's a couple of things that are worth recognizing the terminology that's being used. So additional dose does not necessarily mean booster dose. So in the phrasing that has been recommended, an additional dose would be a dose that is meant to complete an original series of a dose. So there is evidence that has shown that for patients who are moderately to severely immunocompromised, the 2-dose primary mRNA COVID-19 vaccine series may not have been sufficient to produce an adequate immune response. So they are recommending an additional dose in this patient population. That's a separate issue than the booster doses that have been of discussion, and we'll talk a little bit about that as well. So what does moderately to severely immunocompromised mean? I have included the link here, and some of the things that you might keep in mind when you're thinking about moderately to severely immunocompromised would be patients who are receiving chemotherapy, who are actively or for receiving active treatment for any solid tumor or hematologic malignancy. Also, any sort of medications that may cause an immunosuppressive response or an immune deficiency. So there are a number of different medications that have also been identified. So if you are wondering if you have a patient that meets the criteria for moderately to severely immunocompromised, again, if you follow the link there, you'll be able to see all of the criteria for that patient population. Then later on in August, Pfizer's COVID vaccine was fully FDA approved for ages 16 and older. So that's important too in the grand scheme of recognizing what is available for COVID vaccines. The CDC's ACIP COVID-19 vaccine work group most recently met on August 30th, 2021, and we'll be meeting again in mid-September. Actually, when I looked it up again this morning, it looks like it's September 29th that they're going to meet now to review additional information to make recommendations on COVID-19 additional doses, whether it's an additional dose to complete a primary series that's been determined to be necessary, or whether it's booster doses. So looking at what those terminologies mean. So right now, the CDC is gathering information. There are a lot of different opinions on what should be done or shouldn't be done in relation to boosting the current COVID vaccines. And yesterday there was an article that was published in The Lancet that was a viewpoint article. So some of you may be aware of that and may have seen that. That also has raised some controversy. So then this morning that was refuted by some other individuals. And so again, I don't think we have a good sense of whether boosters are going to be recommended at this time, or if that decision for boosters will be delayed. But we are hopeful that after that September 29th meeting, we'll have clarity on what booster vaccinations may look like and whether it's booster vaccinations or additional doses for a wider range of population or specific patient groups, again, that may benefit from having additional doses. It's important to remember always that whenever we administer any sort of medication to an individual, that there is the potential for risk. And so really what is happening at this point is a weighing of risk and benefit and trying to determine at what point it would be best for individuals to receive a booster if that is indicated. As far as pneumococcal vaccines go, I feel like this may have gotten a little bit lost for individuals in the scope of COVID vaccination recommendations, but in June and July, there were 2 new pneumococcal vaccinations that were approved. And these vaccinations are a 20-valent conjugate vaccine for adults age 18 and older and a 15-valent conjugate vaccine. And these vaccines join the previously approved pneumococcal 13-valent conjugate and the pneumococcal polyvalent. Now, for those of you who do like to see all of these together, I did try to compare across the vaccines the current FDA-approved pneumococcal vaccines for adults, the Streptococcus pneumoniae serotypes that are covered by the vaccine, so that you can kind of see what the differences are. So certainly pneumococcal vaccine polyvalent Pneumovax 23 covers the most serotypes. And right now that is the vaccine that is recommended for adults over the age of 65. The pneumococcal 13-valent conjugate vaccine is the other vaccine that has been currently used. And right now the recommendations indicate that this is shared decision-making between a provider and a patient for most individuals, unless they have specific compelling indications for the pneumococcal 13-valent. Now, where pneumococcal 20-valent and 15-valent will land in recommendations is not yet clear. So just like COVID-19 vaccines have a work group that work to identify what the recommendation should be for the population and makes those recommendations to the CDC, the pneumococcal vaccines also have a work group that is working to make those recommendations. So now that these 2 vaccines have been approved, we have to figure out how they fit into what we already have. Will there be any changes, or will this be just another tool in the toolkit? So when I've looked across the vaccines, the only serotype that is not covered by 23 is 6A. So you can see I highlighted that in all 3 of them. Right now, it's hard to know how that one serotype will influence the guidelines or the recommendations. It is likely that it may not have a huge impact unless it is found to be a large cause of disease. So in October, we will see that they will be making some recommendations about whether or not the guidelines should change related to pneumococcal vaccines. So what's important to know right now is that Pneumovax 23 still covers a lot of serotypes, and that is currently what's recommended. And so we will wait until this subgroup meets to determine if there's any other recommendations that will be made about either 20 or 15. All right, so with those few vaccine updates, we want to go into the bulk of our presentation today, which is going to be talking about improving geriatric patient care collaborations with prescribers and pharmacists. So one of the things that I really wanted to be able to do was to go to the literature and to see what has been done already, or what types of information can we find about ways to improve collaboration. So this was a topic that we received interest in developing a presentation for. And so one of the articles that we found was facilitating collaboration between pharmacists and physicians using an iterative interview process. So this was a qualitative research study as opposed to a quantitative study. There wasn't a survey conducted. It was multiple interviews that happened over a period of time. And then the data was combined together a very small group of individuals. So it was 8 pharmacists and physician pairings from a variety of community pharmacy settings, and then providers specializing in primarily internal medicine, family medicine, and geriatrics. So very applicable to a geriatric patient population. So the pharmacist and physician pairing were pharmacists and physicians that generally work together. So not necessarily in the same clinic, but pharmacists that would routinely interact with pharmacists and physicians that would routinely interact in caring for the same group of patients. So each pharmacist and physician in each pairing were interviewed independently twice. The goal, as quoted in the article, the goal of these interviews was to identify issues, barriers, and facilitators to collaboration with the other provider. So they took all of those items and they just made lists, tried to identify common themes. After that happened, each of the pharmacist and physician groups were provided a copy of the list that was generated by both their group and the other group. And then after that, the pharmacist and physician pairing were interviewed together once following their individual interviews. And as quoted from the article, they were encouraged to problem solve together, to share resources and infrastructure that would be needed to effectively implement and sustain the project. They were also encouraged to discuss their own ideas for collaboration that may not have been on the lists. So as far as results go, the pharmacists identified needs on a wish list from those initial pharmacist interviews. The physicians identified needs on a wish list from the initial physician interviews. There were 6 items identified from the pharmacists, 11 items identified from the physicians. They did not record how many times an item was duplicated, which I do think would have been interesting to have to get an idea of maybe perceived importance. If more than one pharmacist mentioned something, more than one physician mentioned something. But instead we ended up with individual items identified and listed out. Communicating these wish lists with one another then helped the participants to brainstorm solutions and identify further barriers. There were collaboration barriers that were identified that I think are worthwhile for us to mention and take into account, and to think about how in our own practices we might be able to overcome these barriers. So the first one was timing of patient care issue communication relative to when the patient care was being delivered. And this was seen from both the pharmacist and the provider's perspective. So looking at a pharmacist, well, starting off with a provider seeing a patient, trying to identify what medication-related issues are there, trying to help solve those medication-related issues, perhaps writing a prescription for a patient that the prescription wasn't going to the pharmacy until several days later even, or being picked up by a patient until later. So the care involved required people, it was inefficient because it required multiple individuals to review a patient case over and over again prior to being able to really communicate why the decisions were being made or why something would or wouldn't work. So it just was very inefficient as far as timing goes. And then the other collaboration barrier that was identified was time to provide patient care in general. So both sets of providers felt like they didn't have enough time to adequately provide patient care and to do some of these things that would be really helpful for their patients in improving their overall disease state management, medication use, all of those things. Another article that we found was recently published in the American Journal, or the Journal of the American Geriatric Society. So this was just in August that it was published, and it was primary care clinician and community pharmacists' perceptions of deprescribing. And this was very interesting as well to note, because I think they had a much more robust reporting from not only providers, but also community pharmacists. And they asked several pointed survey questions, which I think could lead to further evaluation or further description of how these barriers or facilitators might be addressed. So to quote, the survey questions address deprescribing experiences, beliefs, attitudes, influencing factors, barriers, and facilitators. This article, I think, provides a lot of good resources for us as we think about how we can improve patient care working together when we're not necessarily always physically in the same space. So the results. These are the survey criteria that clinicians and pharmacists identified as barriers. These are the survey questions specifically, so I have in quotations the exact survey response that patients or that survey completers responded, and these are the top 3 for each. So when we look at clinician barriers, clinicians felt that patient attitudes toward the medications they take was a significant barrier, the most significant. Insufficient time available to spend with patients communicating deprescribing recommendations was also very high. And then difficulty to communicate directly with other healthcare providers, for example, subspecialists, about deprescribing recommendations. As far as pharmacist barriers, we see some of the same things. So we see difficulty to communicate directly with other healthcare providers about deprescribing recommendations. That difficulty communicating directly when that patient care experience is happening seems to be a common theme that we saw from the previous study as well. Insufficient time to spend with patients communicating about deprescribing recommendations, again, similar in both groups. And then a lack of trust between healthcare providers and pharmacists was seen as a barrier. There were also some other things that I felt were interesting that I wanted to include because I think it's something that we can impact maybe more easily than some of the systemic types of practice models that are hard to change. Finding more time is something that's going to be challenging for everyone in our current healthcare system. But there are some things that maybe we could change that would improve patient care. And these were also listed as barriers by both pharmacists and clinicians. So both pharmacists and clinicians agreed that, quote, lack of education and training related to deprescribing activities, end quote, as well as, quote, lack of access to information electronic health records are barriers. And this is seen as a barrier for both groups. And just as a perspective about lack of access to information electronic health records, that went both ways. So often pharmacists working in a pharmacy separate from an organization. So depending on the setup of your organization, your pharmacist may or may not have access to the medical record. And that may or may not result in more phone calls to clarify things that would have been clarified or noted in a provider note, which can be frustrating for clinicians who are trying to keep their time management going as well. Likewise, pharmacists have access to information like refill history. It can be really challenging as a provider to determine what a next step in therapy will be if you're not sure if a patient is actually using the medication as prescribed, or that is difficult to tell what their refill history even looks like for some medications. And so both providers have access to information that the other doesn't have that could be useful in shared decision-making and in providing optimal patient care. So I've highlighted the 2 here just for emphasis. These 2 were seen by both clinicians and pharmacists. So time and the challenges in communication. So those are areas where perhaps if you are working with a pharmacist in your community, that you can identify some strategies to help improve those. Maybe you have a discussion with your pharmacist or with the pharmacy that a lot of your patients are using to see if there are ways to improve the ability to communicate deprescribing recommendations or to clarify questions on prescriptions. These are areas where we will likely have to be very innovative and creative to make changes. As far as results of facilitators, so these are things that both clinicians and pharmacists thought would help facilitate deprescribing, that would make their collaborations better. And again, I listed the top 3 for each of them. These are the exact statements that were in the survey. So for clinician facilitators, adequate time to spend with patients to discuss deprescribing recommendations, trust between healthcare providers and patient attitude toward the medication they take. So again, some of the barriers we see as facilitators, things that would improve that, improve those interactions, or trying to correct the things that were seen as barriers. Pharmacist facilitators, ability to communicate directly with healthcare providers about deprescribing recommendations, adequate time to discuss with patients deprescribing recommendations, and trust between healthcare providers and pharmacists. So again, we can see commonalities here. And likewise, even though these weren't in the top 3, we still see that there are some things that maybe we can work toward improving that will help all of these things as well. So both pharmacists and clinicians agreed that training and experience with deprescribing, and again, you can see the percentages there, as well as clinical guideline updates that support deprescribing recommendations. We've talked about this in the past too, having some guidance for how to approach the management of patients who are older, because we don't have a lot of evidence for that in some ways. So for deprescribing, so we know when to start medications often, but having a clear understanding in clinical practice guidelines about when it is most appropriate to stop medications for risk-benefit ratio for patients as they get older is not always as clear. Sometimes it is, but not always. Okay, so, and then we're going to use in our case some of the we're going to use the American Geriatric Society's Choosing Wisely, 10 Things Clinicians and Patients Should Question as a framework for looking at one of our patient cases. So if you decide you want to try to find that one while we're going through some of these tools, that will be the one that will be most useful. We'll also talk about some of the other pharmacy organizations that have put together medication recommendations as well for choosing wisely in that initiative. So the American Medical Association has recommendations as part of STEPSforward for embedding pharmacists into practice and collaborating with pharmacists to improve patient outcomes. There is a module that you can complete that is called Embedding Pharmacists into Practice. And within that module, there are different resources. So one of the resource titles is Determining Your Pharmacy Needs and Identifying the Right Type of Support. And the other resource title is Quality Opportunities Checklists. There are a lot of different ideas or strategies that are included in these resources. And one of the things that is differentiated is what is the difference between embedding community pharmacy versus a clinical pharmacist into your practice. And so depending upon the makeup of your practice and how whether you have resources to have a pharmacist in the clinic with you, that can sometimes be a really helpful strategy to catch any sort of questions or clarify disease state management before medications are prescribed and getting to the pharmacy. So that's a great resource to have if you're able to do that. We recognize not every clinic is able to have a pharmacist right there, but you are able to still access community pharmacists and the resources that they have as well. So contacting your pharmacy or contacting the pharmacies where your patients are getting their medications filled at can help you to maybe be able to identify if patients are taking their medications routinely, even asking pharmacists to go through patients' medications with them to talk about how to take them best. Again, some of those general review things are helpful. Pharmacists also do medication therapy management for patients, and they do complete comprehensive medication reviews as well for patients as they get older if they meet certain criteria. So there are ways that you can work with a pharmacist in your practice to improve medication use. Likewise, pharmacists have the ability to provide immunization. So if you have patients who are unable to come in to the clinic during clinic hours, pharmacists are often available for extended periods of time and can provide immunization administration services as well. And pharmacists and providers can create collaborative practice agreements in the state of North Dakota. Even community pharmacists working with a provider to do disease state management, so helping monitor patients' diabetes or helping to monitor patients' hypertension. Those types of collaborative practice agreements can be entered into by physicians and pharmacists as well. So we have lots of options for trying to embed pharmacists into practice. The American Board of Internal Medicine has a number of documents that they have created that are referred to as choosing wisely documents. And I'm not sure how many of you are familiar with these or have seen these, but they are between 5 and 15 items generally of things that you should be thinking about and that patients should be thinking about or questioning as they're looking at overall patient care in different populations. And these are available for a wide variety of things. I focused primarily on looking at medication use in geriatric patients, but if you are interested in other topics, you can find lots of other topics. They're generally produced by a society of practitioners. So whether it would be pharmacists or physical therapists or physicians that have specialty in that area to try to help guide things that they commonly see as things that would want to be avoided in certain populations. So what I have here is a list. I have links to 4 different lists. The first is from the American Society of Consultant Pharmacists. So this is a group that works with a lot of geriatric pharmacology or geriatric pharmacotherapy and making recommendations. This group has a lot of pharmacists that are involved in management of patients in long-term care facilities and also assisted living facilities. So lots of different pharmacists who belong to the group. The American Society of Health System Pharmacists would be looking at pharmacy recommendations from a health system perspective from primarily inpatient. So when you're looking at transitions of care, even for patients who are coming into the hospital, and then patients who are being discharged from the hospital, what are some best practices that can be done to help make sure that we are improving their medication use overall. And then the American Geriatric Society has 10 things clinicians and patients should question. And then the American, it's the Post-Acute and Long-Term Care Medicine Group, the AMDA, they have 15 things clinicians and patients should question. So I am going to pull over to my first screen, the American Geriatric Society Choosing Wisely list so that you can see it. Can everyone see that on the screen now?
Yes.
Perfect. So this is what the PDF looks like. So if you were able to find it, you would be seeing the same thing I do. If you click, when you're on the website, if you click into each of these items, it will give you the information, the justification below. The thing I really appreciate about this is that it's also very well referenced, so you can see what sources all of these recommendations are coming from, and it's updated routinely. So you can see that this one was last updated, I believe it's at the bottom here when they did it, but it was last updated in 2021. So it's really good to see that it's recently updated as well. And they'll tell you when they updated specific things or when they were last reviewed as well. So if we look at this list and choosing wisely, I'm just going to touch on or just review the ones that are related to medications before we look at our patient case that we have. So the first one related to medications is don't use antipsychotics as the first choice to treat behavioral and psychological symptoms of dementia. The second one is avoid using medications other than metformin to achieve hemoglobin A1C less than 7.5% in most older adults. Moderate control is generally better. Don't use benzodiazepines or other sedative hypnotics in older adults as first choice in insomnia, agitation, or delirium. Don't use antimicrobials to treat bacteria in older adults unless specific urinary tract symptoms are present. Don't prescribe cholinesterase inhibitors for dementia without periodic assessment for perceived cognitive benefits and adverse gastrointestinal effects. And then avoid using prescription appetite stimulants or high-calorie supplements for treatment of anorexia or cachexia in older adults. Instead, optimize social supports, etc. Avoid medications that may interfere with eating. Don't prescribe a medication without conducting a drug regimen review. This is really a role for pharmacists. You can do this too, but a pharmacist is uniquely trained to be able to conduct a medication review. And so that's a great area to try to incorporate pharmacists into your practice. All right, so this is the AGS Choosing Wisely list. I'm going to show you also the American Society of Consultant Pharmacists, who primarily works with geriatric patients, so that you can see their list as well. One of their first statements is don't initiate medications to treat new or emergent symptoms without first ascertaining if a new symptom is not an adverse drug event of an already prescribed medication. For those of you who may have attended our last medication-related geriatric echo, you'll remember that a lot of adverse drug events, as patients start getting older, we're more likely to see some of them. And so it's important for us to be thinking too, as we're looking at a patient coming in to see us, whether they're coming to pick up a medication as a pharmacist, or whether they're coming in for a review or to be seen for a new symptom as a provider, to find out or see if we can figure out if this isn't being caused by something they're already on. We also want to not continue medications at transitions of care without a pharmacist or other qualified healthcare professional performing a comprehensive medication review. One of the reasons that transitions of care can be really challenging is because sometimes patients get discharged on medications from a similar class or same class of medications, and then they end up with 2 different medications at home that are for the same thing. And so having a pharmacist, having that really mindful time at transitions of care to review the medication list and making sure that the patient and or their caregiver understands what they should be taking is really important. Don't recommend highly anticholinergic medications in older adults without first considering safer alternatives or non-drug measures. And then don't use anticholinergic medications concomitantly with cholinesterase inhibitors in patients with dementia. And then don't use 2 or more medications known to increase the risk of bleeding without evaluating potential risks and benefits. So it's not saying never use them together. It's always saying keep in mind the risk and the benefit for the patient. These medications include direct oral anticoagulants, warfarin, aspirin, selective serotonin reuptake inhibitors, antiplatelet agents, NSAIDs, and corticosteroids. And then again, this list talks about how it was created and the sources that are available. And this was also recently updated. So keeping those things in mind, we are going to use a patient case that we have perhaps seen a little bit before. And we're going to also take into account things like the Beers criteria to see what we might be able to identify in this case as potentially being something that we could choose more wisely in relation to how we're managing this patient's care. So you have an 82-year-old female who presents to your clinic to establish care. She was last seen by a provider 5 months ago and diagnosed with urinary incontinence, stress. And to date, she reports a dry mouth, occasional dizziness when she stands, and when it's been a while since she's eaten. As part of her visit today, her medications are reviewed for appropriateness. So she has her past medical history here: hypothyroidism, hypertension, dyslipidemia, diabetes type 2, and urinary incontinence, stress 5 months ago. So this is kind of generally what we have. These are pretty common in this patient population. And then if we look at the second page, we're going to see some current vital signs and lab values. We have a Chem7 for you today, TSH and A1C. And what are some things, thinking about the 2 lists that we've just read, the American Geriatric Society list, the American Society of Consultant Pharmacists, what are some things that you're thinking of?
Glyburide.
The glyburide, yes.
Good choice.
Yep. So definitely glyburide is on the Beers criteria as not necessarily recommended to be used in older patients. It can definitely be potentially causing some of the symptoms the patient is seeing. So occasional dizziness, might be hypoglycemia when she hasn't eaten in a while. So definitely glyburide is something we can likely eliminate from this patient's medication list. Her A1C is really quite good. The other thing you might think about for this patient right now, she's on metformin 1,000 milligrams by mouth twice daily. We don't have an eGFR for this patient, but it could be that this patient's metformin dose should be decreased too, now that she's starting to get older. And her
patient ibuprofen. Yeah.
Yeah, so we don't really know. She's on both naproxen and ibuprofen. I don't know that she needs to be on either of them or both. It says she's using them as needed for headaches, but we don't really have a good understanding of what that means. It's definitely on the list of things to consider with increased risk of bleeding, along with that aspirin 81 milligrams.
I'd be concerned about that oxybutynin, the extended release version of it. And I don't really know why she's taking that omeprazole either.
Right.
Which everybody seems to be on a PPI. It just seems to.
Right. So it is definitely, oxybutynin is something that we should be looking at. So when we think about this patient, she's presenting, if we look back at her complaints, she has a dry mouth. We know that oxybutynin has anticholinergic side effects, which we know can be something that we wouldn't recommend for geriatric patients. And she's taking this for stress incontinence, which isn't really indicated for that either. So it could be that she just needs this removed from her medication list altogether. There are some other strategies that maybe could be used to help improve her stress incontinence as opposed to using oxybutynin. And then you're right, omeprazole, it's hard to know why that was added, but that's another medication that we should look at carefully to make sure that our patients have an indication for it. Sometimes omeprazole is one that will get added during a hospital stay and then will stay on indefinitely. Also, omeprazole, since it's available over the counter, some patients will take it because they think they need it or that it will help. So checking to make sure they're not having other reasons for why they're choosing that medication. I always think about when I'm looking at geriatric patient profiles, as well as thinking about risk of falling. And so I also think about this patient, when I look at her blood pressure, she actually meets the criteria for orthostatic hypotension based on her diastolic blood pressure. So we see a change of 12 millimeters mercury between sitting and standing. And so for the definition of orthostatic hypotension, it would be greater than a 10 millimeter mercury change for diastolic blood pressure. And so she is talking about she gets dizzy sometimes when she stands up. So we might be trying to think about whether we should be making further adjustments based on that as well. So maybe adjusting blood pressure medications, perhaps adjusting some of her other medications will help improve that as well. Is she slightly dehydrated? There are lots of things that you might be considering with that as well. Yeah. The other thing that I think we talked a little bit about as being a, so when I talked about barriers and we talked about facilitators and some of the comments that were made by the prescribers and the providers for deprescribing, that last study we talked about, one of the things they talked about was the lack of evidence for, or the lack of guidance perhaps in clinical practice guidelines for medication use in geriatric patients. So we have some guidelines for what's harmful, for things we know for sure are harmful that we would avoid, like the Beers criteria. But then we also don't necessarily always have in a really clearly communicated way how to stop some of the other medications patients are taking. So one of the things I look at on this list is aspirin 81 milligrams. And really, there's not a lot of evidence for benefit of using 81 milligrams of aspirin in as primary prevention for a patient over the age of 80. So the risk of bleeding is often seen to be greater than the risk or than the benefit of using aspirin. And so in this patient, especially with the naproxen and the ibuprofen, I don't know that aspirin would be necessary. That might be one more medication that's contributing to polypharmacy for this patient. So that might be something for you to consider. Also thinking about clinical practice guidelines and what's currently there. We don't have a lot of evidence to guide if or when we would ever choose to stop atorvastatin for primary prevention. And so this patient is 82 years old right now. They're currently doing some studies that may help us to have a better understanding of that. But when you look at the clinical practice guidelines, they don't talk about patients who are over the age of 80. Like the primary prevention is really for a younger patient population. And so it doesn't mean that it's wrong for this patient to continue using atorvastatin. This is a it's a high intensity dose, but it's not the highest intensity dose that the patient could be on. And the patient may be fine continuing taking it, but this may be one of those discussions that you have with the patient if they feel like they're taking a lot of medications, what they would like to do regarding their atorvastatin, if they want to continue using that or if that's something that they want to discontinue. So at this point, we don't have a lot of evidence that says one way or another for primary prevention. We do know that using statins for secondary prevention is important. We have a lot of guidance and information on that, but for primary prevention, not as much. Again, not wrong though, she has diabetes. It would be part of practice guidelines in general, a standard of care to have a statin, but understanding completely when the standard of care might change for geriatric patients for using some of these strategies for prevention would be important for us to have information on as we move forward and as our patient population continues to age. And just kind of adding on to the atorvastatin comment that the only evidence that probably is very strong at this point in deprescribing atorvastatin for older individuals would be individuals who are in hospice care who have a limited life expectancy. So certainly discontinuing a statin at that point has been proven to be definitely reasonable for those patients. And so other patients, again, it would be your clinical judgment on if you think they would need to continue on their statin. But there's nothing that says right now that it's harmful. Also nothing that says it's particularly helpful. We're waiting for the evidence to show us both in geriatric patients. Beyond, I would just comment that there are lots of ways for us to improve patient care. And one of the things I'm most excited about seeing is the clinical trials that are being done now in older adults to be able to determine what the best routes of treatment are for common disease states. So we see a lot of cardiovascular outcome trials that are happening. We see a lot of trials that have recognized that we have not included older adults. And so we want to try and get that information to be able to make the best decisions with the best information. And so I'm looking forward to seeing what the recommendations will be for lots of things. So anti-diabetic agents, medications that we use like statins very routinely in patients to have more of a definitive answer as far as what the best use of these medications will be as our patients begin to age more.
A pharmacist that I really trusted and he knew his stuff and I was working with him, but he retired.
Oh, yes.
Okay, so how do I find a really educated, trustworthy pharmacist in my area? I'm in the greater Grand Forks area and I just don't know where to look.
Right. So I think that there are a lot of really great options. And if I know depending on where you're working at, you might reach out to the pharmacy there. They may have someone who actually has board certification as a pharmacist in your specialty area. So there are lots of areas of pharmacy where, so all pharmacists now go to school for 6 years, have a PharmD degree. And the last year of that training is all clinical experiences in a variety of settings. But we do a lot of looking at what do the guidelines say about recommendations? So looking at guideline directed therapy, but also looking at patient specific factors of making those recommendations and where the guidelines are silent and how we can maybe begin to approach some of those patients, because at the end of the day, the best medications to take are the ones the patients will actually take. And so we try to help take a lot of those factors into play. So I would say there are a lot of pharmacists who are able to help you, Linda, in your practice. As far as the greater Grand Forks area, I think if you are, I'm not sure where you're practicing at right now. If you're at Altru, you might contact the director of pharmacy at Altru, for example, and just ask if there's anyone that you could specifically collaborate with if you're looking to collaborate with a provider or with a pharmacist.
Okay.
If they don't have a specific person, if it's not something like they can come and work with you in your clinic or in your practice area for a designated amount of time, then perhaps they can help you identify what's the best way to get a hold of someone when you have a question. I used to work at the VA in St. Louis, and we had a phone line that was like the question phone line, so that we knew that that was provider questions for, or it was, we only gave it out to certain people. So we had a line that was more of a direct connection in. So maybe there's something like that that could be a quick communication for providers, or some sort of internal messaging system that you might be able to request collaboration through, or a review of a patient chart if that's the case as well. I think that there are a lot of pharmacists who are looking for providers to collaborate with to be able to improve care. I think there are a lot of opportunities that present themselves in pharmacy, just even in community pharmacy, that it can be really challenging when we don't have access to the information that's needed to be able to help or to make recommendations. So even if it's something as, and I don't want to say simple, but as straightforward as helping monitor blood pressures when a patient is between clinic visits, community pharmacies can do that too. So there's lots of things that I think we could work together to really help and get each other information we need to make better recommendations or better.
Thank you. Some good ideas.
Thank you.
Appreciate it. Thanks.
Okay, does anybody have any other questions? We still do have 5 minutes left, so feel free to go ahead and either type in the chat or unmute yourself and ask.
And I think too, the other thing I would add, Linda, if there's a pharmacy that you notice a lot of your patients are getting their prescriptions filled at, that would be a great starting place too for collaboration. I know there are a lot of pharmacists in the Grand Forks area that are really doing some progressive things and looking for collaboration.